Hello. Hello again. Back again.
Back again. So let me start, Sofia, by introducing Professor Matucci. He is Professor of Hematology from Milan, to share with us his point of view on systemic sclerosis patients. Professor Matucci, the floor is yours.
Thank you very much, Professor Economis, and hello to Sophie Mavrogeni. It's my great pleasure to be with you today, and I would like to ask, thank you very much for having my slides so you can see. Today I will enter into the world of myositis and systemic sclerosis, and thereafter Professor Mavrogeni will enter into the world of the heart. So next slide, please. You may see here that, first of all, I wanted to specify precisely the definition, because we are talking about myositis, but in reality, myositis is part of the world of myopathies. That is a broader category where we have a lot of diseases inside, from skeletal muscles, from genetic conditions, from metabolic disorders, toxic myositis. And in specific, in this case, in scleroderma, myositis is primarily an inflammatory event, but we may have also another situation, and you will see that is the myopathy that is mainly linked to the sufferance of the myositis at the beginning, but then also by the malnutrition that characterizes scleroderma patient. The next one, please. And you may see that one of the common clinical elements is weakness. And in myositis, we have a muscle weakness, sometimes pain and tenderness, and also in particular, we have fatigue. And for this reason, the classification of myositis, the next one, primarily has been set. May I have the next slide, please? May I have the next slide, please? Is set upon what we know as idiopathic inflammatory myopathies. And you may remember that we have a dermatomyositis, we have then necrotizing myopathy on immune basis, then we have body inclusion body myositis, and then we have also overlap myositis. And at the end of my presentation, we shall also briefly speak about the overlap myositis that is concerning exactly scleroderma, and you will see with what are the characteristics and the features of this specific subset of the disease. The next one, please. So when we look at myositis and myopathy, it's in reality a mix of inflammatory, metabolic, and also ischemic factor. The next one, please. And you may see here that this is a biopsy of the skeletal muscles. You see a minimal myositis, but you already see the pathological involvement of the capillaries, and you see that these capillaries are thickened. That is a classic feature of systemic sclerosis. The next one, please. And you see here how much the PDGF, that are growing factors that are expressed in particular in pericytes that are practically around the capillaries. So just to remember that scleroderma is a vascular disease, and this is one of the main reasons that characterize also the muscle involvement in the disease. The next one, please. Here you see how much this is important, because you may clearly see how much the vessel wall is thickened, in this case in the capillary, in comparison on the right side to another capillary that is a healthy one, but it's clearly a vasculopathy. And this vasculopathy is influencing the whole evolution of the disease, as well as this vasculopathy is getting worse. Also, the disease is getting worse with a progression of the clinical features. Please, next one. So here you see all the pathological features from the injury of the myofiber to the interstitial fibrosis to the microangiopathy, and you see that this is a characteristic vision of what we see in the muscle of this patient affected by systemic sclerosis. The next one, please. And here we know that, as I told you at the beginning, weakness is the most important element, and that we have to investigate the moment the patient becomes weak, several factors. The next one, please. And you may see here that the moment we see a weakness, the first thing we are immediately thinking is the heart involvement. Obviously, as you may see, this is correlating also with the lung involvement and with, in particular, with anti-centromere antibodies. But first of all, we link immediately the peripheral muscle with the heart. The next one, please. And for this reason, I would like to show here there are two cases. One that is slowly progressing and then develops weakness in a year time. But then, as you may see, that as an additional symptom, this patient has also angina and palpitation, while the other patient has a progressive muscle involvement with a progressing weakness, either of the upper and lower limbs. The next one. And you see here the panel of the whole differential diagnosis that we have to investigate when we are dealing with this kind of patient. Because you see that obviously here there is a whole panel where you have toxicity, for instance, statins, then you have cancer, and we should speak about this later. We have endocrinological diseases like hypothyroidism, and in particular also infectious diseases with viruses or parasites and many others. So you know that when we have to think about this, we have to really have a full panel of investigation that involves mainly internal medicine. The next one, please. So, as I said, the first thing we think the moment we see that the muscle is involved, we immediately jump on the heart because it's a very high risk of developing an inflammation also in the myocardial muscles, even if we know that there may be also the sufferance in the esophageal motility that is due to myositis. The next one, please. And you see that these two patients are undergoing two kinds of examination, because obviously we are immediately looking not only about the antibodies, but in particular about CK, and we measure also, you see here, troponin on both of them, and the proBNP, and also the electrolytes, as well as we think about electromyography, and we should see all these investigations now. The next one, please. So the muscle enzymes are very important because we have the CK and aldolase, and obviously we know that CK elevation, it's sometimes is more pronounced in the overlap diseases, and we shall see specifically this at the end of my presentation. And the next one, please. When you see here that we see the increase in troponin and proBNP, we obviously move to the cardiac magnetic resonance that Professor Mavrogeni will talk to you about later. The next one. And you may see here the panel of autoantibodies beyond the classic antibodies that we have, like centromere and topoisomerase or RNA polymerase 3. We look at all the other panels that characterize the myositis complex. And you see how many they are. And these antibodies are very important because they can teach us a lot and they can drive us in the investigation. The next one, please. And the next one. So the investigation, one of the most useful is MRI, because MRI can show us how much the muscle is inflamed. in particular in the lower extremities and upper extremities, so that we can identify precisely which is the most affected muscle, because obviously if you want to do a biopsy, we should go directly there to make the sampling. The next one, please. And electromyography is very useful because we use this regularly. And in the next one, you can see which are, the next one, please. You can see which are the characteristic, like the fibrillation and the fact that these are found in comparison to the what we call the neuropathy, because neuropathy has a high amplitude, why the myopathy has a low amplitude. So we can immediately understand if this is due to the weakness, obviously is due to the involvement of the nervous system or of the muscle. In this case, we see fibrillation and the low amplitude that are characteristic really of the muscle involvement in systemic sclerosis. The next one, please. And the muscle biopsy is something that is very important to us, because we can identify, in particular, the MHC expression and also the infiltrate into the endomesial and perimesial areas. And obviously, we may immediately characterize the level of inflammation as well as the level of myopathy. The next one, please. And we should not also forget that the biopsy will be able to give us also the level of the necrosis that we may see, that will help us to differentiate the myositis in scleroderma from other kind of myositis. So the three questions now. The first question is malnutrition, because as I told you, in systemic sclerosis, the GI involvement is inducing a malnutrition. And obviously, following malnutrition, we enter into the world of sarcopenia, and this is found in a large part of patients involved that have the involvement of the muscle. The next one. But moreover, the question is: do we really need also to rule out malignancy? Because malignancy, we know that is tightly linked to myositis. The next one, please. And in particular, in those patients that have the RNA polymerase III positivity. So we know that the myositis with an RNA polymerase III positivity is potentially linked to a hidden cancer. So that's the reason why we have to investigate as much as possible the presence of a hidden malignancy in these patients that specifically have the RNA polymerase III. The next one. However, it's not only this, the antibody, because when we have this kind of presence of the antibodies plus the myositis, moreover, we should do the investigation about cancer, because in particular now we are trying to use treatment that are immunosuppressive. And I just present here the fact that the allogeneic CD19 targeted CAR-T therapy is very useful in severe myositis and in systemic sclerosis. So we know that this kind of treatment is very useful, but in a condition like a hidden cancer that is not investigated and discovered, may create really a lot of problems. The next one. So there are now, in conclusion, there is a specific subset, and this specific subset is called scleromyositis. Why is it called scleromyositis? Because the autoantibody profile in this patient is not the classic one that foresee usually anticentromere, antitopoisomerase, and RNA polymerase, but it's a lot of kind of different antibodies that characterize this specific scleromyositis group. These patients have obviously weakness. They have sometimes a normal CK level, in 1 out of 3 patients. And obviously, these patients are not so aggressive as the other ones. And the next slide, please. But we know that the association is very, very important. And you see in this slide, this is a work of many years ago, but it's just telling us that up to almost 60% of these patients can have the specific anti-PML-SCL antibody and is characterizing, therefore, a specific and different subset from the others. The next one. So in this slide, you may see that the autoantibodies, they determine the presence of the muscle involvement, and the muscle involvement is linked tightly. You see here in the red frame, the myocardial disease. And you see all the others that we can see. But in reality, the fibrosis, the vasculopathy, and the myofiber necrosis are characteristic that are present in this patient that are bearing the antibodies like the PMSCL, the KU, the U1-RNP, and also the others. So we know that we must always get the full-blown picture of the antibody pattern. So we should not restrict our investigation to the ANA or only to few antibodies, but we really have to investigate a larger panel of antibodies, starting from those that characterize myositis, from those who characterize also scleroderma. And when you have this panel, you may start to understand how will be the progression of the patient and which will be the specific organ that can be involved, in this case, in particular, the heart and the esophageal tract. The next one, please. So we may say in conclusion that myositis in scleroderma is a harbinger for myocardial involvement, is characterized obviously by weakness, that myopathy may be either secondary to myositis, but also secondary to malnutrition and sarcopenia. That is, I would say, a leitmotif that we see in this scleroderma patient. And then we have a specific subset of scleroderma that is called scleromyositis, which must be always taken care of, as it may induce myocardial involvement. And we should never forget that in this patient that have scleromyositis, but in particular those who have an RNA polymerase III, cancer should be always ruled out. I thank you for your attention, and I'm ready to take your question. Please.
Congratulations, great talk. We really enjoy it. I'm just wondering how often is the combination of scleroderma with myositis, because in many cases.
Okay, yeah, thank you, Sophie, for the question. So we have two kind of possibility. The first possibility is that myositis is widely distributed in systemic sclerosis, either in the limited disease that is approximately 70% of our patient with anticentromere antibodies, as well as in the topoisomerase antibodies and RNA polymerase III. However, we have a percentage of 10-15% of these patients that are characterized by the other antibodies, as you have seen, the PMSSCL, the KU, and all the others. So in this patient, you can find the myositis, and this is characterizing a different pattern with a different timing of evolution. So these patients are usually less aggressive, but the heart involvement, for instance, and you will speak now in a few minutes about the heart involvement, is much more aggressive in the topoisomerase antibody patient than it is in this other small subset of scleromyositis, because it's very slow. Okay, very slow. And you can recognize, a few days ago, I had a patient, a young patient, that came to my office with Raynaud phenomenon, ANA positivity, and PML says 75. And immediately I did the CMR, the magnetic resonance. And what did I find? I find only fibrosis and LGE, late LGE, so late gadolinium enhancement, just to tell me that it went very slowly, very slowly. You know, so the characteristic of heart involvement are always a little bit different. We have acute disease like the topo 1 or RNA polymerase, and we have the slow one that usually is the centromere and also the other antibodies.
Second question. Do you know if this kind of fibrosis in muscles improves after the antifibrotic treatment in tendon? Because we have already the study.
Yeah, we don't know yet. But as I showed you in the picture, we have the vasculopathy. Okay, the vasculopathy is characterized by the significant fibrosing procedure of the intima and the media.
Yeah.
So we are a little bit behind in the knowledge, but the antifibrotic we know now that should be used as soon as possible in this patient, also to avoid the fibrosis of the vessel wall. Because as I told you, we have the inflammation and we have the vasculopathy that is unfortunately inducing an ischemic situation that is not helping the muscle. And plus, on this, we pile up with the gastrointestinal involvement and malnutrition. Okay, so we have three elements that are one upon the other that take away the health of the muscle.
Yeah, can I ask you to this end, is there any difference in the treatment in those that they develop myositis compared to those that they do not?
I'm sorry, I cannot hear you.
Let's say that we have a systemic sclerosis patient, one with myositis, and another one without. Is there any difference in the treatment?
Yes, there is a difference in the treatment because we have acute events. Like I've told you, there are patients that develop an acute aggressive myositis, and there are those who are very slow myositis. Usually the slow myositis is characterized by vasculopathy and then malnutrition. The acute one is very inflammatory. So obviously we should use anti-inflammatory drugs, immunosuppressants, as soon as possible. So obviously we use also immunosuppressants in the other that are going slower, but in the other that are very aggressive, we specifically sometimes we need an induction treatment. You know that we don't like to use steroids in scleroderma because of the kidney, but sometimes they may be very helpful. And we use methotrexate, and we use now also rituximab. That is an impressive drug also from this point of view.
Mm-hmm. Okay, thank you.
Okay. Okay, no more questions.
I can't see any questions in the chat, so we may listen to you, Sophie. Your